IORT is mainly used for breast cancer at our institute here in Mannheim. It is used as a single treatment in low-risk patients, as also shown with the target E results. But we also use it a lot for boost, in this high-risk patients collective, as we have in the target BQR cohort. One main topic on this IORT use, especially for KV, as we use here in Mannheim, is that as risk final assessment takes place after surgery, we always have to discuss also the option that a sole or single IORT that is planned might end up with an additional whole breast irradiation, because in some cases we see in final histopathology some risk factors which qualify them for a more extensive treatment, for having more local control, for example. But the good thing about KV IORT is that this is no risk for us. So if we plan IORT as a sole treatment and we see some additional risk factors, we can just add a whole breast radiotherapy because it's the same dose. So this is also our workflow, that we plan IORT and then we can afterwards see if this is the whole treatment or if we have to add anything. This is different in intraoperative radiotherapy with electrons, where you definitely use different doses for boost or for a single treatment. So here you have to plan your treatment really before surgery. And this is different at our department. So we are really flexible somehow and can rely on a final histopathology outcome. All of our cases are discussed through the different multidisciplinary team discussions. We have 16 different tumor boards. So we call it tumor board here in Germany. Usually it's the same as multidisciplinary team discussion. And here we definitely discuss also always the option of IORT. And for breast cancer, we even notice why IORT, for example, is not possible. And in other MDTs like sarcoma or something like that, we discuss if IORT is feasible or possible in this multidisciplinary team discussion. And all of our team members are aware of intraoperative radiotherapy. We use the intrabeam system from Zeiss Meditech. We only have this machine to do intraoperative radiotherapy, so we don't use any other device. This is a mobile device with a stand, which you can move from one OR to the other. And it has a mobile X-ray source, which is about 2.3 kilograms of weight. Yeah, so you can really take it and put it into the stand. And this source emits a low kV X-rays with a spectrum up to 50 kilovolt. This is the technique that we use. We have already talked about breast cancer, our main topic, but we also have other treatment indications like sarcoma and sarcoma recurrences. We have treated also head and neck cancers. We treat a lot of abdominal recurrences. I think the main recurrences come from rectal cancers, but we can also treat different recurrences, usually in the abdomen. We have treated already eye lymphoma and skin lesions, because we also have different applicators. So we have spherical applicators to treat within the abdomen or in the breast. We also treat brain cancers like glioblastoma, but also metastasis. We have studies running on that, and we have this flat applicators for the skin lesions, and we have also cylindrical applicator for vaginal cuff treatment. So it's really a broad spectrum to treat intraoperatively. What we do is we discuss these options within this multidisciplinary team discussion and fix them somehow. And afterwards, but also beforehand, usually we discuss these different options with the patients. In the special context of intraoperative radiotherapy, we always have to discuss this, that IORT can also be combined with external beam radiotherapy, for example, and that also a planned IORT might not be feasible due to maybe technical, organizational, or anatomical reasons. So this is something that we really have to communicate in the context of intraoperative radiotherapy, because sometimes it's not feasible during surgery. And we also communicate this option with the patients in the shared decision process somehow. So we also discuss every other option and then really decide on the basis of the preferences of the patient if this is a way to go for them, or if they accept maybe some treatment just to have maybe a time preference somehow. Yeah. So IoT is really yeah, a method that you can really use for different indications. I think that's really a strength of intraoperative radiotherapy. And especially with this intrabeam system, you have this different applicators which you can use for different indications. I think one main aspect is that the doctors should really be familiar to the technique they use. And sometimes it's also preferable to visit maybe some centers that already have an experience and can share their knowledge and experience that they already have to really hire or expedite the learning curve somehow. And also I recommend that you speak to all members of the MDT. So they also should be familiar and used to the technique, know the data, yeah, support the treatment. So the education of the team, I think, is really a way you have to go, and you have to catch them all, yeah, to also implement a workflow. So I think it's also something that you really have to implement at your side, that you have a workflow. You need to define the corresponding persons and so on. And then I think IoT might really widen your spectrum of treatment. And it's really an interdisciplinary approach. So you're really in close contact to all the different surgeons and are really within this process of multidisciplinary treatment.